Now I want to spend some time discussing newborn hyperbilirubinemia. Um, in other words, jaundice. And remember, we talked about neonatal jaundice, and that jaundice is that yellow discoloration of the newborn skin due to a byproduct of hemoglobin and releasing this yellow pigment called bilirubin that's not being conjugated, so not being taken up by the liver. And we know that the majority of newborns experience some type of jaundice called physiological jaundice. And this is because newborns are essentially hemoconcentrated, meaning that they have um, large amounts of red blood cells circulating through their bodies, and these red blood cells have short lifespans. And so there's more red blood cells, and then they break down quicker. And because the liver of the newborn is immature and not able to produce enough albumin, which helps uptake or helps conjugate this bilirubin to be excreted eventually through the intestines, that we get this jaundice. We get this over amount of unconjugated bilirubin due to the immaturity of the newborn liver. So, what we're going to talk about is more specifically talking about pathological jaundice and causes of that. Again, here just for review, the four types of neonatal jaundice. You should know these four, and then know the how to differentiate between physiological jaundice, which occurs after 24 hours of birth, and pathological jaundice, which occurs within 24 hours of birth. And so again, this module is going to focus on that pathological jaundice and causes of this hyperbilirubinemia. So there's various causes of newborn hyperbilirubinemia, and we've talked about a few of them. For example, cephalahematomas, the short lifespan of fetal red blood cells, and the increased amount of red blood cells that newborns are born with. But as you see highlighted in red, we're going to focus on Rh and ABO incompatibilities and their impact on hyperbilirubinemia. Left untreated, these unconjugated bilirubin can then pass and travel into the brain, causing a condition called connectors. And so these are high levels of bilirubin in the blood. And here you can see that it's irreversible, causing severe CNS issues and other neurological problems, even leading to death. And so signs and symptoms of connectors is listed on your right. And this is rare because of the information that we know about hyperbilirubinemia, its causes, and ways to decrease the risk of pathological jaundice. So, in addition to encouraging feeding, especially if a woman is breastfeeding, because we know that the bilirubin is excreted through the feces. So, if we get the baby feeding, then that helps to move out the bilirubin. But we also use a therapy called phototherapy. And the appearance of um, this UV light apparently speeds up the conjugation of bilirubin by the liver. And so UV lights or cool white daylight or quartz halogen lights can be used. And so um, phototherapy can happen under a special warmer where there are Billy lights. Those lights are directly on the baby, that shine down onto the baby, or a device called a Billy blanket. And so it's a little device that can be placed directly on the newborn skin if the mother is, let's say, feeding or just wants to hold the baby, but we still need to get that, we still want to decrease the amount of bilirubin in the blood. And so this allows for an opportunity to continue attachment, developing attachment and bonding. And then when a baby is under those Billy lights, he or she is completely undressed except for the diaper. And then continuous exposure to these lights um, could be harmful to the retina of the eye. So they have these little shades, little coverings over their eyes to protect the retina. With the use of phototherapy, you may notice that the stool may be a little different color. It may be more green because of the excess bilirubin that's being excreted. And so nursing interventions is that we certainly want to, assessments I should say, we want to watch out for signs and symptoms of dehydration. And that would include, if you recall, the newborn fontanelles, that anterior fontanelle, if it's sunken in, that's a sign of a potential sign of dehydration. Okay, a bulging fontanelle is a sign of some intracranial pressure. So other things, changes in vital signs, we want to check the temperature because this baby is under a light and we don't want it to get too hot. Checking the skin, making sure that again it's still well hydrated, and again making sure that we protect the lights. And not all babies are going to be cooperative with those little shades over their eyes, and so you want to make sure that you keep an eye on that, or talk to the parents and making sure that they do so as well. In severe cases of hyperbilirubinemia, blood exchange transfusions can be performed. And again, these are high risk newborns in situations where there had been RH incompatibility, and we'll get into that, and it'll make more sense after we go through these next couple of slides. One of the main causes of hyperbilirubinemia, when we're talking about pathological jaundice, is hemolytic disease of the newborn, meaning destruction of red blood cells, newborn red blood cells. And again, with this destruction, we already have this immature liver that's not able to conjugate the bilirubin, the byproduct of red blood cells. So if we have more red blood cells that are being destroyed at a abnormal rate, then this increases the chance of hyperbilirubinemia, and moving into severe anemia for the baby if red blood cells are being attacked. And so two types of issues can cause this hemolytic disease of the newborn, and that's RH incompatibility, where there can be this isoimmunization, or ABO incompatibility. And so we'll discuss both of these conditions in the next couple of slides. So here I just wanted to provide a quick review of basic concepts of immunity. So we know that immunity is when the body produces antibodies to destroy antigens, certain types of antigens. And then isoimmunization is antibodies against antigens from the same species. So, it's not foreign because it's coming human to human, and this is where we talk about blood incompatibilities. There's an isoimmunization that develops. Okay, so knowing what an antigen is a foreign substance, knowing that immunity is when the body develops antibodies against these antigens, and then iso immunization is developing of antibodies against antigens from the same species. So we'll talk about blood types when we talk about ABO incompatibility, A blood, B, AB, and O blood types later. But also with our blood type, we talk about another antigen, our RH antigen or RH factor. And RH, again, is another antigen specifically called the D antigen. And if an individual has that antigen, then they would be considered Rh positive. If they don't, then they're Rh negative. And we should note that most people have the D antigen, so they're Rh positive. But when a woman is Rh negative, meaning she does not carry the D antigen, it can pose a risk to her unborn children due to this Rh incompatibility. So when we're thinking about genetics and we're thinking about the Punnett square, which I'll give you some demonstrations in the next couple of slides, Rh negative is homozygous, right? And so that you need to have, and as you can see on my visual here, two lowercase d's. So that mother is Rh negative. Now the father or the donor can be either Rh positive or Rh negative. And so Rh positive can be in the form of two uppercase D's, or which is homozygous, or it can be heterozygous where there is a uppercase and lowercase d. So then what does that mean for the newborn? And let's look at it in these next couple of slides. So the mother is Rh negative, and then the father is Rh positive, but his Rh positive is heterozygous. So that means he has an upper and lowercase d. So then that means that the baby has a 50% chance of being Rh negative and a 50% chance of being Rh positive, correct? If the father is Rh positive and his Rh positivity is homozygous, where there's two uppercase D's, then this baby is going to be Rh positive for sure, right? And so this would be an instance where we start talking about the mother potentially developing antibodies against an Rh positive fetus. So if we have a pregnancy where the mother is Rh negative and the father is Rh negative, there's no potential risk for Rh incompatibility, right? Because if both parents are Rh negative, then the fetus is going to be Rh negative. So in another scenario, a mother in her first pregnancy is Rh negative. The father is Rh positive, and we don't know the fetal Rh factor at this point, but we know that there's a possibility that the fetus can be Rh positive. And so with the first pregnancy, there's usually not a risk to that fetus because for the most part, there is no mixing of fetal blood with maternal blood. The maternal blood is what is being supplied into the placenta and through the umbilicus, through the umbilical cord, through the vein to supply nutrients to the fetus. but the fetus's blood doesn't contain um, when the baby is transferring um, waste products and things like that back to the mother. It's not containing red blood cells. So theoretically, there is normally no mixing of fetal blood with maternal blood, and so that remains separate during pregnancy. In instances where there's trauma or invasive procedures such as amniocentesis or chronic villus sampling, where there can be an increase of that mixing. Okay, so let's just say we have a first time pregnant mom who's Rh negative, the father is Rh positive, she's had no um, invasive procedures, no amnios, no CVS, she's had no trauma to the abdomen. So that fetus is generally considered safe. However, if we do not treat this mother with a medication called Rhogam, and I'll get to Rhogam, she can develop antibodies against Rh positive blood, and that can impact subsequent pregnancies if that baby or those babies are Rh positive. So if that mom never receives Rhogam during her uh, first pregnancy, again, her following birth or pregnancies can be affected, where she develops antibodies and becomes sensitized, meaning that she has isoimmunization. So she's developed these antibodies against antigens from the same species, right? From the human species, meaning blood. And so this will affect subsequent pregnancies if those fetuses are Rh positive. So now this Rh negative mom and her partner, who is Rh positive, are pregnant for the second time. She did not receive Rhogam in the first pregnancy, and now she has isoimmunization. So there is antibodies in the maternal blood already that are now going to start attacking fetal red blood cells if they're Rh positive. Because remember, the mom's blood is transferring to the fetus. And so that blood contains antibodies that will attack that positive, that antigen D, which is Rh positive blood. And so in utero, this fetus's red blood cells are being attacked by the mom, and that can cause severe anemia to these babies. And these babies can develop this hyperbilirubinemia because they have this abundance of bilirubin because the red blood cells are being destroyed, and bilirubin is a byproduct of it. So when this case of maternal blood having antibodies against the positive antigen D found with the positive Rh factor to the fetus, you can develop a condition called hydrops fetalis, which there's severe anemia, the fetal heart starts to decompensate, and then there can be cardiomegaly, enlarged liver and spleen, because it's trying to work harder to produce albumin. And so treatment has to happen in utero, okay? And this is through a complex procedure called PUBS, percutaneous umbilical blood sampling, and transfusions that occur. And this, can lead to fetal death. And so it's extremely important that we screen women at the prenatal for their not only their blood type but their Rh factor. And if a woman is Rh negative, we want to, at 28 weeks, screen her again, and give her, we're going to check her titer to make sure she's not sensitized, meaning she hasn't developed immunization. And we're going to administer a medication called Rhogam. And we do it at 28 weeks because Rhogam has lasts for 12 weeks. And if you add 12 to 28, we're right around 40 weeks, and the baby most likely will be delivered, if not already delivered, shortly after. Rhogam is also given after any procedure where there or trauma where there could be that unlikelihood of mixing of fetal and maternal blood. So if a woman is Rh negative and she had an amniocentesis or chronic villus sampling, she's going to get Rhogam after that procedure. If she's been in a car accident or has experienced some type of abdominal trauma where there is a potential for mixing, if she's Rh negative, she gets Rhogam as well. And these are only if she hasn't developed antibodies already, because Rhogam can't reverse antibody production that's already taken place. So again, to help with better understanding is a review video of Rh incompatibility. And, for some students, this can be a tricky topic to understand. And so again, if after, hearing my lecture and looking at this video, there's still some questions or concerns, feel free to contact me. So now we're moving to discussing incompatibilities related to blood type. And we know that there are 4 blood types. There's A, AB, B, and O. And the characteristics of each one of these, for example, A blood type only has the A antigen. So then that means that people with A blood type automatically, naturally have antibodies against B blood. B blood types would be the opposite, where they have an antigen to B and have natural antibodies against A blood. Individuals who are AB blood type have antigens of both A and B, therefore they have no antibodies. That's why they are considered the universal receivers, meaning they can receive blood from anybody because they have both antigens and therefore have no antibodies that would attack the donor blood. Then we have O blood type, which has no antigens but has antibodies to both A and B. So O blood type is the universal donors because it contains no antigens. Therefore, A blood can get it, B blood can get it, AB blood can get O. However, individuals with the blood type O can only receive blood from O individuals, okay? Because they have naturally occurring antibodies to both A and B. So they couldn't get blood from a person, an A blood type or B blood type, because they already have antibodies developed and would automatically attack, and that blood wouldn't be compatible. And so that's significant when we talk about pregnancies and ABO incompatibility. So when we compare that to RH incompatibility, it can be more common, right? Because we reduce the risk of RH incompatibility with the use of Rhogam. But with blood type incompatibility, it's already in the body. The person is born with, based on their the blood type that they're born with, they already have these antibodies. However, it's less severe than an RH incompatibility because the fetus's blood type is less expressed, meaning those antigens, regardless of their blood type, is weak, and so it doesn't signal to the mom's blood in utero to start producing antibodies. So with ABO incompatibility, the mom has to be O type, and then the father has to be anything but O, A, B, or AB, and that the fetus has to be A, B, or AB. And the other difference is that the first pregnancy can be affected automatically because the mom already has these antibodies. She already has this isoimmunization against blood types A, B, and AB. And so these babies, if the mom is O and the baby is anything but O, may have or at increased risk for hyperbilirubinemia once delivered. So there are a couple of tests that are diagnostic for RH and ABO incompatibilities, and two to be familiar with are the Coombs test, direct and indirect. So direct meaning taken directly from the cord blood, looking for any maternal antibodies on fetal red blood cells to see if this mom has developed antibodies, if it's a RH incompatibility, or if she's O and the baby is anything but O, if any of those naturally occurring antibodies have attached to the fetal red blood cells, thus heightening our awareness that there's going to be increased red blood cell breakdown, leading to increased risk of hyperbilirubinemia. The other test that we can do is a indirect Coombs test, and this is testing the mother's serum to see if there are any free floating, meaning not attached to anything, RH, anti-RH positive antibodies circulating in her blood. If there is, in relation to RH incompatibility, then she can't get Rhogam because she's already developed antibodies against RH positive blood. And so again, Rhogam doesn't reverse that, and so that she already has developed antibodies, and she's has developed isoimmunization. So know the difference. Direct, is there a direct attack on the fetal red blood cells, or indirect, does this mom have free floating antibodies against RH positive blood, or the RH positive antigen? Then there's another test, Klein-Auer-Betke test, that estimates or gives us a guess if there's been any fetal mixing. And this would be used again if a woman had some type of abdominal trauma, she was in a motor vehicle accident, or a victim of intimate partner violence, or she fell, anything that could cause trauma. We do a blood test on the maternal blood to see if there's any RH positive, any fetal blood mixing in the blood, and then that can determine if she needs Rhogam. So I've talked a lot about Rhogam, right? And so Rhogam basically tries to prevent the mom from becoming sensitized. All right. And what Rhogam does is it blocks, it kind of hides and shields that Rh positive antigen from the fetus so that the mom doesn't recognize it and therefore she doesn't develop antibodies. It is a blood product, and so safety would be, when we do any administration of medications, we need to do the rights, that we know the right patient, the right dose, the right route, the right medication. All those things need to be checked when giving Rhogam, and usually there's a two-person check with this because it is a blood product. And Rhogam is only given if the woman is not sensitized, if she has not developed antibodies already. So that's why at this 28-week mark antepartumly, in the prenatal period, we do another Rh test and a titer. Again, just checking to make sure that there is no evidence of antibodies in the blood. And if it comes back negative, then she gets that Rhogam right at that, she gets the Rhogam at that time. So around 24, between 24 and 28 weeks, when she's doing her screening for gestational diabetes, we also do another check, especially this is for women who are Rh negative. And if she comes back showing no antibodies, then she gets Rhogam prenatally. Then this Rh negative mom again will be tested if she through the indirect Coombs test, and if she's not sensitized, will get another dose of Rhogam prior to discharge, again to prevent any development of antibodies, because there has been some evidence that there can be an increased risk of mixing of blood right at the time of the placenta is the cord is clamped, that there could be potential there of mixing, and so there is a potential of antibodies being developed. And so it usually takes 4 or so days before antibodies can be developed. So that's why we have this 72-hour window in the postpartum period to administer Rhogam. And then we talked about other times where Rhogam would be administered if a woman had a miscarriage or an elective abortion and she's Rh negative. We want to give her Rhogam after any invasive procedure, chronic villus sampling, or amniocentesis. So here just reinforced what Rhogam is and the action of Rhogam. Again, if there is any questions or you need me to clarify anything regarding RH and ABO incompatibility, please do not hesitate to give me a call.